So, I mentioned I was in women's health, had, helped a lot of women through this process. Didn't feel like we always had the right tools to give them. Didn't really have maybe some of the education that I have now. So when I approached, my transition time, and I was a little on the earlier side, my mom went through a little earlier, and so I knew I would be. And just based on that fact that you follow your mom's pattern. So I really wanted to do it naturally. I was, all about supplements, and I still am about supplements. I think they're hugely important. But I sat down with a wise and trusted medical friend, and she said, Laura, nothing is going to replace your estrogen. Nothing will hit your estrogen receptors. You have over 300 estradiol receptors in your body. So, yes, you can support yourself with certain things, but nothing's going to take the place of that. And that is natural. That's what your body's creating. And so it's bioidentical. It's chemically structured like your own. So, I looked at my risk factors, my medical history, my family history, and I decided based on some science and research, like I said, I signed myself up for a conference. And that was really for me too. It wasn't just for my patients, but for myself. And I told myself, I'm going to give myself 3 months. I'm going to see if this makes a difference, because you can't start hormones and then say, I'm going to think in 2 weeks, I'm not better. It does take some time. And so you have to approach it with, okay, I'm going to put a time frame on it. I'm going to give myself 3 months and see how I feel, see how I respond. And I never have turned back from that. Now, tomorrow, if something changes in my medical history, that could change. But for now, that's been the best decision for me.
So were you going through those symptoms? Were you starting to feel, I'm
Fatigue.
not myself, and fatigue, brain fog, those things? And who did you turn to at this time? Was it kind of, you did your own lab work and assigned it to yourself, or did you go to someone?
I went to my physician.
Okay, I didn't know.
Yeah, I went to my physician.
Physicians may push back on that, so you had a good physician.
I had a great physician, and then I also, I guess I had enough connections in the medical community to kind of reach out to some other people as well and get their experience. And then, going to the hormone conference was hugely impactful for me because it gave me some resources that we didn't have then that we do have now. So like books, articles, all the things that we refer our patients to now. Podcasts
are great YouTubes that are by credible people.
Exactly.
All right, this is fascinating. I cannot wait to get into it. So let's jump into the rest of the conversation.
Okay, let's go.
Thank you for finding During the Break podcast. This podcast is not possible without my fantastic sponsors. So do me a favor, Google them, Facebook them, research them. Do business with them because I trust them. I have done business with them, and so can you. Alchemy Med Spa and Wellness Center, the Vascular Institute of Chattanooga, Optimize You, Guardian Investment Advisors, The Barn Nursery, Chattanooga Concrete Company, and RoofingCo.com. Thank you to my sponsors of During the Break podcast. Now, let's podcast.
All right, so I took a picture off the interwebs, the WWWs. That's where I went. I went WWW, and I found a picture of my guest with her scrubs on and the stethoscope. And I've had her on the podcast a number of times, this podcast and other podcasts, and I posted it on my Facebook page. And I go off Facebook now, my personal, at least 7 to 10 days a month. Every month, I just deactivate it for a week or two. And it's been very healthy for me. But I posted a picture of like, hey, look forward to talking about this topic. And on my personal page, I promote stuff not like I used to. And the feedback was everybody knew my guest. I'm like, oh my gosh. All of a sudden, it was like, I love this. She's awesome. I sent people her way. It's a long way around the intro barn of Laura. How you doing?
I'm good.
Did you see
Clint.
the response?
I did. I paid them well. No.
No, I think you probably
some longtime friends that are super sweet to me.
Well, and you've probably added value to a lot of people's lives. All right. So
well, I hope so.
You have. We've had this kind of conversation. It's been a couple years, and my questions may change. Science may have changed. I don't know. Things may have changed, or this may be the perfect time to have a conversation, and new ears hear it.
Absolutely.
But with that being said, I used to introduce my guest and all of their accolades. Now I kind of let them do it because they know what they do better than I do. So tell everybody your full name, what your license and your title is, and your qualifications, where you work, and kind of what you do. And then we're going to talk about everything pre, peri, and post menopause.
Good job.
Did I get
Good
that
job.
right?
You got it. You got it.
I think my contribution to this conversation is probably peaked, but go ahead. Go ahead. Tell everybody.
Well, my name is Laura Chastain. I was raised in the Chattanooga area. I am a family nurse practitioner by training. I trained with my undergraduate at UTC and my graduate degree at Emory University, and then worked in various roles, most recently the last 15 to 20 years in women's health, where I, gained valuable knowledge about all ages of women, and really enjoyed that role, worked with some amazing providers, and learned a ton of information just about the comprehensive health for women.
Yeah.
And in that role, saw a huge need for more hormone education, felt the need myself, saw that it was an unmet need, and we really were leaving women feeling hopeless or feeling frustrated in their hormone transition. And so sought out some additional training on my own, and then joined with Josh Porter, a community friend, first and foremost. Thought really highly of he and his wife, and he and I had some conversations, actually ran into each other at a hormone conference. And, as he was starting Optimize You, he was just getting going, and he said, yeah, if I ever, get this thing moving, would you be interested? And absolutely I was, just with all of my background and then additional training. And then since then at Optimize You, I have obtained the Menopause Society certification that focuses on women in menopause and the menopausal transition.
Wow.
And working on another certification through WorldLink Medical for biohormone therapy, bioidentical hormone therapy. So, that is where we really focus now, is looking at hormone optimization.
Mm-hmm.
I like to describe it as metabolic health for women and men, because we're really looking at how hormones impact their long-term health in a cardiovascular sense, brain, bones. We're looking at more than just that particular hormone, but in the entirety, the lipids, the thyroid, the other hormones in the body.
Well, not only that, but your joints and your mental state, your happiness, your relationships.
Yes.
The energy. And I talk about this, of course, with Josh, and you've been, like I said, a number of times. It's just, we sometimes, and Ed Jones is really good about this too, nutritional, but it's sometimes we think, well, my knee is my knee, and my knee only affects my knee. And if I live with a bad knee, I live with a bad knee. And
We've
really,
siloed health.
It's right.
Into different
that affects your hip,
compartments.
and that affects your back, which affects your mental state and your sleep. And we don't understand that once you push this domino, it actually hits all the other things.
Exactly.
I wanted to pull back before we jump into the menopause heavy conversation.
Okay.
So stay tuned, ladies and men who care about the women in their lives and live and walk alongside the journey with women in their lives, because this is just as much impacts your life and happiness as theirs, just on a different level. And you have a role to play, by the way, dudes. I mean, there's a lot of patience that goes in this, and I think if guys realize at a certain age that we too deal with hormones in a different way, it may give you a little bit of patience and understanding, and quit being such an asshole sometimes. Seriously, I mean, just give people some space. They are working on something that a little bit of.
Right.
It's like knowing a little bit of karate and trying to teach somebody that knows a lot of karate. They're like, yeah, we live with this.
Yeah,
Thank you.
exactly.
Oh, really? Just go take a walk, eh? Okay, thank you, sir. I appreciate your input. But I was going to back up and give you one more just pat on the back. You're a podcast professional now.
Oh, you're kind.
I think
Clint.
the first time you came in here, I was your first podcast.
I think it was.
And we had
very
to spend.
nervous. Yes, very nervous.
You came in today, coffee in hand. Let's go. You could be chewing gum over here. What do you got for me?
Oh, that's
You're
funny.
all relaxed.
No, it's because it's you, Clint.
No, that's
you're
now.
You're
Okay.
the podcast professional.
Okay.
And so I'm at ease knowing that we're doing this together.
You also have gotten much better at the bull crapping of society. Let's get to the stuff you don't BS about. Let's get to the stuff that you live a life doing. Let's start with the basics.
Sure.
And the basic that you came in, I asked you to help me define some terms. I've heard pre, peri, menopause, post-menopause. people in this, understand this will be elementary stuff here at first. People in this may not know those even definitions and how what's the difference between them.
Yeah.
Give me the definitions of those terms, please.
Okay, so premenopause would be prior to menopause. And so we're going to look at basically about 3 categories. So premenopause, perimenopause, which is a little less defined, but definitely important. And we need more studies in that area. It's the least studied area. Okay. And then postmenopause. So premenopause would be like after puberty up until the time when periods start to change by about 7 days.
Well, real quick.
Sure.
So premenopause is everything from when they first start to when they start. They're
premenopause. They're premenopause. They're not peri.
Right.
They're pre.
Yeah,
you know. So after puberty, when periods have started, into the fertility years, the years where you're childbearing or able to do that. And then up until when periods start to change by about 7 days. That is the first stage of perimenopause. Now, this can happen in the late 30s. It can happen in the early 40s. But we know by age 45, all women are at perimenopause. And we can say that pretty definitively based on studies. We're also looking at lab values. So when we look at pituitary hormones that give signals to the ovaries, those are going to start to change. So prior to perimenopause, if we draw your labs and you're not on a birth control pill that's altering hormone levels, so we're just looking at natural hormones, then we should be able to match up your progesterone level, your estrogen level, or estradiol level, and your FSH, follicle stimulating hormone, with the phase of your period that you're in. For instance, if you're in the first 2 weeks of your period cycle, that's your follicular phase. So all those hormones should match up unless there's a problem. So that kind of gives us a signal that something could be changing. And so we look at the FSH. It usually is over 25 if you have entered perimenopause, but not always, because perimenopause is a very volatile, changing time when we see estradiol levels almost in a reverse puberty fashion declining.
Okay.
So in puberty, we see the estradiol, I wish I had a graph I could show you here. The estradiol is going up and down like a roller coaster.
Gotcha.
And therefore, all the changes in puberty and mood changes, body changes.
I have no idea what you're talking about.
I know you don't. Yeah.
I was
I'm
just
sure
smooth transition.
It was just
what,
about 10 years?
Yes.
You're pretty,
my birthday's next week, so we've been a while from puberty.
Same. So perimenopause is just we're reversing that. The estradiol levels are going down, up, down, up. So depending on when we draw those labs, it may not show perimenopause. It may look normal, but the patient doesn't feel normal. So again, late 30s to mid 40s. The average age of menopause is 51. So perimenopause can last 4 to 10 years prior to that. So let's say your menopause is at 46. Well, 10 years prior, you're in your late 30s. And a strong indicator of how you're going to age and how you're going to go through this transition is your mother. That is the strongest indicator is how your mother went through and when they went through. And a lot of times women don't know that. That generation, I mean, that generation may have not talked about it as much. They may have had early hysterectomies. A lot has changed since then. But that is a strong indicator as to how you're going to go through this transition and at what age. And so then postmenopause would be when you have not had a period for 12 months. So back up, that period in perimenopause alters by about 7 days. Then you move into the second transition stage of perimenopause where periods stop for about 2 months, at least 60 days. And then you'll eventually not have a period for 12 solid months. And that's your line in the sand. I'm in menopause. So what makes it difficult is if you have had a prior procedure like an ablation where you don't have periods or a hysterectomy. We can't use bleeding pattern to dictate that. So we have to go based on labs and symptoms. And sometimes that is just, being really patient, walking through the process with a provider that can monitor your labs regularly.
Okay, because you saw me writing over here.
Yeah.
I'm like taking notes
I
in
know.
school.
It's making me a little nervous.
No, I know. Well, because my brain, I forget things.
Yeah.
There's people who will listen to this podcast who will understand that I forget things quite a bit. She has a lot of patience, by the way. The reason I'm bringing that up is I wrote down how often should I get labs. Like if I start noticing this and I'm maybe pre or peri. I know something is going on.
Yeah.
Should I come talk to you? Is it I get labs every 3 months, every 6 months, every month for a while, or is that just very independent on each person that comes in the door?
I think it is. I think
Okay.
it depends on your level of wanting to do something about that and your level of being bothered by that with your quality of life.
Yeah.
But in an ideal world, it would be great to do those labs about every 3 months, which is what we do at Optimize You.
Because then you'll catch something.
You'll catch it. Yeah. And you can intervene if you would like, And so everyone, I feel like, comes in at a different phase of first their understanding or education around the topic and their tolerance of their symptoms or their recognition of the symptoms. And so that's huge part of what we do is educate.
So you had mentioned, and then I kind of that. I want to finish up the post part, and then we're going to talk more about symptoms and treatments and the myths that surround this stuff, and the good and bad. But so let's say you said if I've gone 12 months without bleeding, there's a line in the sand. Unless there's been a prior procedure, then we're going off labs. Let's pick that part out. I've gone lab work and other metrics. I'm in menopause.
That's postmenopausal.
That's what I asked. So that's the line. Anything
the
past
line.
that line is now postmenopausal.
Postmenopausal.
Okay.
Yeah.
All right.
I used to be told that menopause was like one day because you're in perimenopause until you hit 12 months.
Yeah.
You're in menopause
Right.
that one day, and then you're postmenopausal.
See, guys, we don't know this. We think menopause is a phase, not a phase, but a transitional period. It can last one day, 10 years. We have no clue very, very, often.
Right. And
Yeah.
a lot of women don't either. And a lot of providers don't as well, unless you've had some specialized training that really focuses on the body changes, the hormone changes, the symptoms that can appear in different phases. And so it is a very unique process for each woman.
Yeah.
Everyone's going to present differently. Some are bothered by acute symptoms like hot flashes, brain fog, fatigue. Others aren't. But we do know that hormones affect more than that it affects our brain, our bones, and our heart, which, heart disease is the leading cause of death in women.
Yeah. I want to stop right here for a second, or I want to kind of use this as a way to pivot.
Sure.
And this is, if you're comfortable with it, let's go through the symptoms of someone who may just be entering into the next phase or someone who's post, because to your point, it will represent differently.
Okay.
But we ought to give people at least some signs that it's not just hot flashes, because that's the check the box.
That's what you think of, right?
Okay. True or false, Miss Laura? Have you heard, and I'm not going to look at you, I'm looking the other direction for people. Have you heard from some of your patients that they've had doctors say, just turn on the fan?
Yes.
Okay.
True.
Just making sure.
True. Yeah.
Because then that sounds pretty dumb, and that makes me feel like I might have been able to give the same advice and been cussed out for it. Just put on a fan. That's not really acceptable advice from someone. And medical profession are great. We all need them.
Absolutely.
But sometimes they're humans too and can give less than stellar advice.
It's true. You know, as providers, if we don't know, we need to admit this is not my wheelhouse. There's things, I'm not going to go and try to fix your, broken ankle, because that's definitely not my area. Now, Josh Porter might be able to help you with that. But, or he might know somebody that could help you.
That would be it.
Yeah.
He knows somebody.
Yeah.
So let's go to the symptoms.
Absolutely.
Yeah.
So the symptoms would be primarily, and these are just things that I hear from women and have read in studies. So when we're talking about perimenopause, women usually know something's off. They can't always articulate it, but they come into me and they're like, I just know I'm just not myself. I'm not sleeping as good.
Okay.
My PMS is a little more severe. I'm a little more moody, irritable. I can't multitask as well. My joints are starting to hurt. I'm having a little bit trouble with remembering names or dates, and I'm having just that lack of clarity of thought.
Yep.
So they know something's off. And so there's an interesting article that looked at perimenopause, and what they found was that when they surveyed over 5 million women, or let me back up, 5 million women had Googled the term, I just don't feel like myself. And so they took a group of women and they surveyed them and they said, what does that mean to you? And the list is probably 75 symptoms long, so, but they categorized that into 5 categories, those being like brain fog, joint pain, mood, low sex drive, difficulty with sleep. And so when I have a woman come in And I'm hearing this. I'm like, would you say you just don't feel like yourself anymore? And they're like, yes, that's it. I just don't feel like who I used to be. I feel like I'm losing part of myself. I had a woman last week, when I said, some women describe this as just kind of losing part of themselves. She really just broke down into tears. She was like, that's it. That is exactly what I have felt.
I want to keep you talking about the symptoms, but the reason I think these conversations are so important, because just the normal public, we fail to do what we were talking about earlier, tying these things together. Because if I'm sitting in front of my wife or you're sitting in front of the mirror and you say that out loud and you don't have anyone to turn to, that is easy to make that about a relationship. I've lost myself.
Right.
Well, the only, and then the husband gets, what do you mean you've lost yourself? We've built a family. We've got all this time together. What do you mean? How can I help? And there's nothing it doesn't matter if you bring more flowers. It doesn't matter if you, seriously.
Yeah.
You can try to work harder at something that's not a problem that one can fix in a relationship. And I think sometimes we just look at this and we go, well, this is just the way Mother Nature or Father Time works. When in reality, there are things we can do to help. I wanted to make that point because what you just said is heard a lot. I feel like I'm losing myself. I'm not who I used to be. And we easy to attribute that to things outside.
Right.
And we take it out because that's all we can see. So they come to you though.
And then the labs look normal.
Yes.
So we say, no, you're normal. So then women are left,
No
frustrated.
Answers.
Right. Frustrated. So we know that is a cardinal symptom of perimenopause. I just don't feel like myself. And so we can correlate that with age, period, pattern, like if they're losing, their period isn't as heavy, it's gotten lighter or more frequent, but it's changed. And then looking at, their labs as well. And sometimes we see it in their labs, sometimes we don't. So those would be the symptoms I see in perimenopause. As you move through menopause, you're going to definitely see periods change. You're going to see more known symptoms like the hot flash, more things that we associate with menopause. About 80% of women will have hot flashes, but that's not always the primary symptom, or they're very manageable sometimes, and sometimes they're not. Everyone's different. But hot flashes, brain fog, vaginal dryness, again, low sex drive, sleep is still interrupted usually. I'll see a woman, and this is classic. They'll come in, they say, I can go to sleep, but I wake up around 2 a.m., 3 a.m., and my to-do list starts. Like I'm going through all the things I need to do the next day, or things I need to, emails I need to respond to, or things I need to do for my family, and they can't get back to sleep. So that's a cardinal sign. And so sleep, sex drive, joint pain, brain fog, vaginal dryness, hot flashes, weight gain. I mean, we see that and a lot of times weight changes, mid-abdominal weight gain is what brings a woman in to me, and so that's a very bothersome one as well. Their body is changing.
Well, this is an assumptive question. You can correct me or affirm it and take it deeper if you want to, but if we don't address these things, then they do become other problems, right? If I don't address my weight gain, I can develop, my joint pain could be more tied with it.
Yes.
Or diabetes, or these things that all of a sudden manifest themselves. This is why I was talking about that domino effect. If I don't address it, then the thing that was a symptom actually becomes its own manifestation of a problem.
Yes. And, we know that women, when you look at men and women and compare their health status prior to menopause, looking at blood pressure and heart disease, for instance, men usually have worse blood pressure or heart disease than women until menopause. And then women outperform men, and their blood pressure starts to worsen. Their lipid panels start to worsen, and heart disease becomes more prominent. And so, just like you're saying, those symptoms, if we don't address those symptoms and look at the root issue, then it can create a new problem for us.
Right. I bet you do get a lot of people breaking down. And me and Josh have talked about this for both men and women, but on a more for the male side of it. Men will, when we get in there, we start having these conversations around difficult things. But a doctor nowadays, and it used to be this way more, I think, becomes more of a therapist sometimes. If you find one you trust, And if if a lady's sitting in front of you and they're bearing their soul, you're going to get a lot of emotions before you've got to kind of uncover that, I guess what I'm trying to say, before you can get to the problem, right? You got to let her be her.
Absolutely.
And I'm not saying every woman's like that, but
yeah, I mean, I think it's a time we set aside to really talk about the things that we just kind of power through when we're, going about our day, taking care of families, working a job, taking care of aging parents or relatives, And so when they come and sit with us, they can kind of block that out and say, this is what I'm dealing with, So I see a lot of women who say, I've just learned to power through because that's what I've always had to do.
It's expected.
Yeah.
There's a lot of expectations on women in the world.
There and men as well.
Yeah,
but that, that time set aside where we can just really ask the right questions,
right.
That will pinpoint how they're feeling. Because sometimes, like I said, they can't articulate that very well.
Okay, so do you want to go through some treatment options first? Because not all hormones are created equal. Not all treatments are created equal. And I'm thinking there's other things, because I want to talk about supplements.
Okay.
I want to talk a little bit about food.
Okay.
Importance of exercise and all this. Do you want to talk about the treatment stuff, or do you want to spend a few minutes on the hormones and the myths around the heart and how sometimes in the medical profession we'll poo-poo hormones because they may not know? Would you like to just address
let's
that
start
real
there.
quick? Yeah.
I mean, you're the boss.
Yeah, let's do that. Let's go for that. I'm getting that recorded. That's going to be my new phone tone when people call me. You're the boss.
Oh, that's awesome.
Yeah. So let's go with the myths.
Okay, so the myths. The WHI trials, which was the Women's Health Initiative, most people are aware of it, but I see people all the time who are not. And, I was trained in the late 90s, early 2000s when all of that information was coming out.
Okay.
And that was a trial that the NIH did to the tune of about $1 billion. And they looked at synthetic hormones. So they're looking at conjugated estrogen and progestin, which is not what we use today. But they came to some conclusions that, in a nutshell, they misrepresented and reported that they were statistically significant, but they weren't. And those were around breast cancer, heart attack, and stroke.
Okay. And
so now we have a huge awakening in this community. And if you follow any of the menopausal, they call themselves the Menopause. But they're all on social media, and they are
There's some
re-educating.
great merch you can buy for that
exactly.
too. They got their own gang sign or something too.
Yeah,
exactly.
Go for it. But they have, been providers. They've taught this, believed this, and then understood because of a book called Estrogen Matters. Really, he was the first. It was written by Avram Blooming. He's a breast oncologist. And quick story, his wife got breast cancer. He treated her or had her treated. Then she went through menopause and she said, I'm taking hormones. And he said, no, you're not. And she said, well, then I'm going to go jump off a cliff. And he was like, whoa, let me look at this. And so he went back and looked at all that data. And really, he has rewritten the story for hormone therapy because he uncovered a lot of statistically inaccurate reportings around breast cancer, heart attack, and stroke, and colon health. And so he wrote a book called Estrogen Matters. It's in its second edition. So that came out in the fall. I would recommend any woman in perimenopause especially to read the book because it does help reframe a lot of our myths, fears, gives us important scientific data around the preventative aspects of hormones or what that can help with in terms of our heart, brain, bones, colon, and our longevity. And so, he helped to, rewrite this story so that we don't have to believe all of the things that we were taught, And so for me as a provider, it helped me to kind of step back and say, wow, this isn't exactly true. And so, you do the best you can with the information you're given or you're taught. But I think as providers, we always have to step back and say, what is this based upon? And so a lot of people are doing that now. And there's a huge awakening around, and re-education around the preventative aspects and the health benefits that can come from hormone therapy.
You can't know better. You can't do better till you know better.
Exactly.
And then when you know better, your expectation is to do it.
You have a responsibility.
So the heart, the stroke, and
breast cancer.
That was proven not to be a significant
finding,
right.
Especially around the estrogen only arm. And again, we're talking about synthetic forms. We use bioidentical or body identical forms now in the forms of estradiol and progesterone. Progestin, which is a synthetic version, is not the same as progesterone.
But see, as laymen, when I hear that, they sound so close.
They sound close, and unfortunately, some medical communities still put them under the same umbrella.
Oh.
They are not, and they do not carry the same warnings or risk. And so we want to use the micronized bioidentical progesterone. It's chemically structured like our own body. And so is estradiol. And so now we use those bioidentical forms, and they are much different, even though sometimes we still fall back on those old studies. It's hard to change what you were first taught.
Right.
You know, in the medical community, and Dr. Blooming talks about this in his book, we hold a confirmation bias. That being the first thing we're taught, we're going to hold on really tightly to that.
That's true in religion, football fans.
Everything.
Once we know it,
right,
and it's part of our identity, by God, I know it.
It becomes our belief system,
right.
right? And so we have to step back and say, what are our beliefs based on?
Yeah.
Is it science? Is it myth? Is it a professor that taught us that one time? Is it a friend who went through an experience?
Right.
Not to discount those, but not to discount anyone's experience or struggle, or, you know, if you had a friend who had breast cancer, it's going to be really hard to change your belief around that.
When sometimes it's correlation, not causation, too, right? Sometimes
exactly.
I'm predisposed to ABC. I happen to be on testosterone.
Right.
Somebody could look at it and go, oh, well, he was on this and it caused that.
Yes.
When in reality, I may not have been on that at all.
Yes.
My genetic had a flip switch on it that Clint was, you know, or I may be other bad lifestyle choices. Either way. Okay, so there's some of the myths. Are there any other myths that you want to get out of there? So if somebody's listening to this, they're struggling, and one of the reasons they haven't come to somebody like you is they've heard. Is there anything else that we may have heard?
Yeah, so in that trial, they also said that you should stop hormones after a certain age or after a certain time period.
The older study. Okay.
And so that has changed. The Menopause Society has come out with a new statement, basically, and new studies have shown that really, unless something changes in your health history, that's not necessarily the case. And so, not everyone knows that. And a lot of patients are told, you really need to come off your hormones, but there's not a reason really why.
When does that normally happen? Is it like a year past menopause? Is it a year? When does that normally happen?
When someone would tell someone that?
Yeah, when does that?
Probably like around age 60.
Oh, really?
Yeah, or in the 60s is what I would say. Now, the WHI trials said you should stay on hormones no longer than about 5 years. So they really were just getting women through that transition phase and not thinking about those preventative aspects or the health benefits that you're going to get in terms of your heart, brain, and bones.
And muscle mass. And all
absolutely.
And we're going to talk about, we're going to move into things that people, because this is the part people are really probably wanting to get to is, okay, you got all that.
Yeah.
What the hell can I be doing for it? But to that point, again, I want to say that's another reason why you find someone like you and Josh that I trust. Because if I'm 65 and I'm 60 or something's changed on me, I may need to take a break for some reason.
Yes.
I may be going through something else and you go, hey, we're going to take 6 months off.
Yes.
We're going to do this instead. You're going to see me more frequently. But again, having someone I trust is the key.
Absolutely.
Yeah.
Absolutely. And like you said, having regular check-ins with that person, because this area is changing so fast. There are new studies coming out, even in the last year, that show brain benefits, bone benefits, heart benefits. And so, just being up to date on that.
Right. All right. Let's get into the part where, okay, we've identified the problem, what the problem might look like. We've identified the symptoms. We've kind of cleared up some myths. Laura, what the hell am I supposed to do? Fix me. Fix me. So,
Clint, that's another podcast.
Yeah,
that's a whole nother episode.
Well, that's the only reason you're here. I'm trying to get some sneaky therapy. Well, so maybe we should frame this around when people come in and they sit down with you, depending on where they're at, is exercise good? Are there supplements I can take? How good is sunlight for me? Should I... Therapy, I have no idea. I just know I need help, Laura.
Sure.
So what are the things that seem to work and what are those dependent on?
So when you look at hormones, they're a tool in the toolbox. There's a lot of other tools that exist too.
Right.
Hormone health is, there's a prominent urologist, Dr. Kara. He works with Dr. Morgenthaler, and they're kind of like the father of testosterone, you know, or fathers of testosterone. And so they talk about hormone health in 4 pillars that affect that, and that being exercise, diet, sleep, and stress. So we know those 4 categories are going to affect your hormone health.
Okay.
So, you know, you can break down into each category. Well, what would be ideal, you know, in a perfect world that we have no distractions in, you know, or what's our goal here? Muscle mass is so important. You know, when I was growing up, it was all the fat-free craze, and, you know, cornflakes for breakfast were fine because they were fat-free.
That's right.
Endless cardio,
Sugar's fine.
Step aerobics, endless cardio, you know.
Leggings. You had the leg warmers?
Oh, of course.
Thank you
And
very much.
the plastic water bottle.
Absolutely.
Let's add that in.
The headband and the big hair. Shout out to the,
Yes.
yeah, go for it.
That was a great decade.
Yeah, it was. It was fantastic.
Great music, right?
Absolutely, yeah.
But we've learned a lot since then that really that muscle is key to our longevity. We know we lose muscle mass as we age every decade. And then when you get into menopause, you don't have those hormones unless we're optimizing those that will help, you know, build the muscle. And, you know, and that's both estradiol and testosterone. That's going to help with our musculoskeletal system. There's a whole new term, the musculoskeletal syndrome of menopause. Again, that's another area that's being looked at.
What is that real quick? Because I got people that be interested in this.
That would be like the ability to make, you know, create muscle, the ability to joint pain, looking at inflammation in the tissues like plantar fasciitis, frozen shoulder. There's a whole syndrome that's associated now with menopausal women.
Wow.
Yeah, Dr. Vonda Wright, she is an orthopedic surgeon that she has coined this phrase and written a paper on it. So, like I said, there's a lot of new data out there, that being one of those. But so we know we lose muscle. We know we're faced with, you know, some weaknesses in the musculoskeletal system. And so definitely exercise is where we want to focus and building that muscle for the long term. And then as far as like diet and nutrition, we know our protein intake is so hugely tied to that. So 1 gram per pound of ideal body weight is what's recommended.
You threw a word in there I don't like.
Uh-oh.
Ideal. What's the ideal body weight? Because if I weigh 220 and I want to be 200, should I eat a pound for 200 or a pound for 220 to maintain? You know what I'm saying?
Right.
So you're saying a pound for ideal body weight? Or is that a little weird? Okay.
Ideal body weight.
Okay.
And, you know, that is much more complex than just us saying eat protein. You know, we've got to look at some new standards. You know, BMI is not always the best indicator of where we are with our weight based on our bone, you know, size and muscle mass. So we're huge proponents of looking at a body composition scanner, like something they have at Nutrition World, like the Sika scan or a DEXA scan, that can look at visceral fat, look at hydration, look at the skeletal muscle in each limb and your torso. So
very specific.
Getting with someone that can help you with that. If those, you know, if that's a goal you're working toward, can help you when you're, you know, stepping on the scales and seeing a weight that you may not like.
Can I hijack it right here at the food before we move on to the other silo, the 4 things you can control or you can look at? So when I said food, I wrote down supplements too. Mm-hmm. If you're not comfortable, it's a good thing about recording a podcast. I can ask this and we just don't have to answer it.
Okay.
But seriously, are there a couple of key supplements that I should look at maybe taking? Again, blood work aside, I know I need my blood work, but if I'm going through menopause or I'm in one of these stages, is it omega-3?
Yes.
Do I need to check? Okay, good. I'm glad I nailed one. Right? Are there other things you go, hey, odds are you need to make sure these 2 or 3 supplements are getting a little help?
Yeah. I really defer to Nutrition World a lot because they are the supplement experts. But they have the core 4, and I always recommend that we at least start there. And that would be your multivitamin, your omega-3, your vitamin D, and magnesium. Magnesium glycinate is a specific form of magnesium that helps with sleep and calming. So a lot of my women in perimenopause will start on, you know, if they're having trouble with sleep, I'll suggest that along with some progesterone. But starting with those core 4, and then if you have a predisposition to, you know, joint pain, or you have another medical diagnosis that is causing a problem, let's add to that. but at least start with the basic 4.
Gotcha. Okay, perfect. That's where I was going to get to. So you mentioned the exercise, how important that is, and I'm assuming that's doing like some basic compound movements,
Progressive
activity.
overload, walking, all of the things that are going to build muscle, support not only the sympathetic nervous system, but the parasympathetic. So walking to support, your brain, your calming the nerves, because we feel a little more on edge when we're going through these transitions. So walking is huge to kind of bring the system down.
And if you think about that, it depending on what time of year it is, if I can 2 birds, 1 stone it, I get my walk in and some sunlight.
Absolutely.
All
Vitamin
sudden,
D, natural vitamin D.
Mental health.
No
one being around me right now.
Yeah, exactly.
The hell away from everybody for a good 30 minutes. That might help a little bit.
I love like an after meal walk, just 10 minutes, just getting up. It kind of resets my thought patterns, just focuses me for the rest of the day, that sort of thing.
I've heard, too, balance as you get older is super important, and hand grip strength.
Grip strength.
And even for women.
What's your grip strength?
I don't know. I've not had it tested.
Oh.
It's strong enough. I know this. Ed asked me to open something for him the other day, so I'll tell Ed.
There's the competition right there, right?
Well, no, but I've just learned that through Ed, and I always default to of course, for men, it's just as important to have balance and grip strength as for women, too.
Right.
Especially if they're indicators of overall health. And we forget as we get older, especially, and I maybe it's true for men too. It just seems like more women fall into their 60s and 70s because they don't have the core strength and they've stopped doing these things that you're talking about.
Right.
Which just leads one thing to the other.
Yes.
I don't address the hormones. I don't have the muscle mass. I don't quit moving as active.
Yeah, and they all kind of work synergistically.
Yeah.
So if I give you hormones and you go sit on the couch, you're not going to necessarily age as well. Right. I mean, you're going to have some protective benefit from your hormones, but we've got to have the movement and the good, nutritional support, and then the sleep. The sleep is huge. 7 to 8 hours of, and that's probably on the low end.
Do you have a routine around your sleep?
Somewhat, yes.
I feel like
teenagers.
You feel judged.
I have
right
teenagers.
Now. Don't ask me that, Clint Powell.
No, I try.
Yeah.
I mean, we're all in process together, right? Like I am there.
I'll take it off your shoulders. I suck at a routine for sleep. I will try. Here's how bad it is for me. I will try, and it will work, and I'll hate it, and I'll go back to the stuff, and I'm like, yeah, but this Netflix series is on, or I'm going to check my phone right before I go to bed, or I'll leave the white noise on behind. So I guess I'm judging myself as much as anybody else. It does benefit you to have a little bit of I'm closing shop routine. I do this, I do that. I keep my phone away, noise. And
I do have a little bit of that, but then, like last night I was really sleeping well and my daughter comes in and is like, Mom, should I submit this application for this? And I'm like, yes, do it. Just stuff like that. There's going to be interruptions. There's going to be life around you. So that's why I say, having some goals that you can shoot toward, and mine would be, I take my supplement. I actually take my supplements at night. I usually do like Epsom salt bath, for like 10 to 15 minutes. Of course, brush my teeth, wash my face, take my hormones, and then I get into bed and read, and then usually, fall to sleep. And then when I wake, I try not to look at my phone first. I'm trying to start the day with some light and some reading, and then I like to work out in the mornings. So that's kind of where that would be ideal for me. But
health is more than just putting hormones in your body. So that's why I think this conversation is important, because you want to give women and men, but this is focused more on women. You want to give women the tools, and one of the tools that I think is the most important is the hormone therapy. But then there's these other things that can help too.
Right. Absolutely.
That we just, again, I just dismiss it. Oh, my morning routine, I don't have 15 minutes. Okay, well, that's important.
Absolutely.
It's critical.
Yeah.
If you're dealing with things, right? So the sleep, the movement, the food, and the supplements. And was there another area?
Stress. Yeah, which is, an ongoing effort for all of us, right? We live in a fast-paced world. We have lots of demands around us. So, again, stacking these habits, finding, it's James Clear, the guy that wrote Atomic Habits. He says, find the easiest way to implement the most effective habit. And he doesn't say it that way, but that's my interpretation of it. So, for instance, taking a walk outside after lunch, you're walking, hopefully sunlight maybe, or at least some outdoor natural light. and then hopefully just clearing your mind,
But stacking habits.
Stacking
habits you said is critical. The smaller habits add up to big differences.
Right.
Yeah.
Right. So just trying to do those things on a regular basis, making that a part of your routine is important.
I'm going to give Nutrition World one more plug, and I cannot remember the name of them, but I've turned several people on to these, and they're fantastic. They're they're little gummies.
Is it the anxiety?
Yes, that's it. And so I take them. My sister, I know there's another person who's got a very, very high stress. His wife is in a high stress position, prominent.
Yes.
She loves them. And I'm just telling you, there's nothing illegal about them. They just take an edge off.
They have L-theanine, and I can't remember. Ashwagandha. Okay.
Yeah. Have you ever tried one?
I haven't. Well, actually, I have tried one, maybe.
Don't take whatever it says on the bottle. Take one.
Take one? Okay, because I'll be too chilled out.
Yeah. At night, I'll let you make your own decisions. You read the label. I don't give medical advice on here. Talk to your local, professional before you take it. But at night, from time to time, I will go higher than one, and they're just really good at pulling the edge off.
Oh, that's good to know.
That might be something good to
add to my walk. I'll chew a gummy as I'm walking.
You might want to chew half. You're not
okay, half.
Yeah,
I still have half the day left, right?
Yeah, go half.
Yeah.
I guess my point on that is, again, you do refer people to Nutrition World.
Absolutely.
And if stress is one of those things, this is a way that, and the women I'm referring to are in their 40s and 50s. So they are, they're in the middle of what you're talking about, and these things help their mental clarity a little bit. You mentioned, we don't need to talk about testosterone, but you mentioned two different hormones for women as we're wrapping this thing up. What are the names of the two hormones you talk about? There's
estradiol,
and the other one is the
progesterone.
Okay. Is that the one that's the bioidentical? Those two?
They're all bioidentical.
Okay. Are those the only two?
Well, we give testosterone to women too.
This is where I was going down that road. Can you tell me the difference in the three, like how they affect my body and why I would get one or the other or a combination of? Because we hear these things, but they all just sound, science terms to us.
So your ovaries are making estradiol and testosterone and progesterone. And so when you go through menopause, you really don't make any of those. I'll back up. The adrenal glands do make a small percentage of testosterone. But our primary source, is not functioning anymore. So we offer all three to women, that are in menopause if they're a candidate. And there's benefits to all three, but they synergistically work together. Okay. So primarily estrogen or estradiol, you're going to think of in terms of like brain fog, vaginal dryness, hot flashes, all your cardinal symptoms of, menopause that you think about. Progesterone, we're going to think more sleep, calming. It's going to be help with mood. It's called the happy hormone.
Okay.
And we really give progesterone in perimenopause and perhaps testosterone. Estradiol is reserved for closer to postmenopause. We can start it early when periods have been missed for several months, or someone is super symptomatic. But we're cautious because, if the body is still making its own estradiol, we don't want to give too much on top of that, And then testosterone, is really overlooked in women a lot of times. And I think there's a lot of fears from providers around giving testosterone or misunderstanding of how do we dose it? How do we give it? What levels do we look at? But just like in men, women need testosterone. In fact, women make more testosterone than estradiol, believe it or not. It's just measured differently. And so the levels look smaller on a lab report, but they're measured differently. And so we make more of that than we do estradiol. And so testosterone's been associated with, or the lack of it would be with energy, sex drive, muscle tone. So like women may feel like they're getting more flabby under their arms or on their sides. So testosterone is hugely correlated with that.
Right.
It's also now being studied more in mood, brain fog, the clarity of thought. So, in men, we see those benefits.
Right.
We see them in women too. It's just to a lesser degree in terms of dose and amount. So women need that. It's not a male hormone, which is it's been referred to so many times.
And men, by the way, we make all of them. We don't just make just testosterone either. Now, we don't make the estradiol, I'm pretty sure, but maybe we do.
Well,
I don't know.
You convert a little bit of your testosterone into
Yeah.
estradiol, and it provides some benefit in men too. Whole nother podcast, but gives you some of those benefits.
You can tell this, by the way, if someone's ever abused steroids the wrong way, there are signs that will pop up that they may be creating quite a bit of estradiol. Yeah, so we'll leave that.
Yeah.
That's a podcast I'll have with other friends of mine.
Yeah, there you go.
But my point on all this is it's a recipe. It's
Yes.
not just one ingredient,
Right.
and that recipe can change from age 40 to age 60. And
Absolutely.
your job is to come in as the chef of this and go, okay, it's time to change this recipe up a little bit.
Yes.
Does that sound?
Absolutely.
Yeah.
And that's why we really like to refer ourselves as practicing precision medicine, because it's not a one size fits all. Not every woman gets the same dose based on certain lab values that we look at as well, besides just their hormone levels. So we'll change dosing based on those. We'll look at their response. So every woman gets a unique plan. And I think that's so important, that we just don't, say, well, here's your hormone and we'll see you next year.
So if I'm a client of yours, am I getting my blood checked every 3 months?
Every 3 months.
Every 3 months.
And then we have a follow-up, about 7 to 10 days after that, once the labs are back. So we can talk about your symptoms, your response, maybe tweaking the dose. And I think it's important to remember that in perimenopause, things are changing regardless. So you're not always going to feel great. You're not always going to feel badly. And what we come in and do is try to balance that for you. But there is still changes that will occur. And I think it's important to approach that with some patience and realistic expectations that this is a transition time. We're going to walk through that with you, and we're going to get you kind of to the other side. And then you're going to feel a little more even.
Right. I'm going to give you the floor. If there's something I did not ask, because I'm not I might miss stuff. If there's something you want to say to women, no matter where they're at in the process, and then make sure people know how to get a hold of you, how they get in touch with you, so they can say, maybe it's been 2 years, maybe they addressed this 2 or 3 years ago, and they've changed, they forgot that they should stay in touch, or maybe they're just now in the middle of it and they haven't talked to somebody, or they don't like the fact that a damn doctor said turn the fan on. Or I'm not going to give you any hormones based off a 1990 study that's been sort of debunked, or at least, shed more light on. I want to make sure they know how to get in touch with you or Josh or someone at your clinics.
Yeah. And I would just encourage women to, do some research, do your homework. We're all busy. We work jobs, have families, as we've talked about, but your health is important. And so if you have a goal for 2025, if you're in this phase of life, I would say make it this, to read Estrogen Matters. Seek out someone who is certified and has studied this and can give you some information around the science. Science is changing, so find someone who allows you to ask questions, who listens to you, and does not make you or discount your feelings, because this is real. And women, if you live long enough, you will go through menopause. That is a fact. And so we're all going to face this, and we need to not only face it with understanding, but some patience and an open-mindedness, that not everyone will approach this phase the same. We'll all have different symptoms. And so I think just knowing that, we're available if you'd like to see us, and you can find us at the Chattanooga, Hickson, or Cleveland locations. We have one phone number, 423-206-9753. You can call and press, any option, and we'll get you to the right person. And if you don't know, just take that step. Let us look at your labs, talk to us. Let us give you some information to educate yourself. If you don't know, or if you're ready to take that next step, we'd love to take that with you.
And there used to be, and I don't know if you still do it, they can tell them no, and I can cut this part out, but it used to be that if you called in, told them you heard about it on the podcast, I think there was a small discount for initial blood work. One thing we didn't talk about, the way you administer them.
Yeah.
Are they weekly injections? Are they pellets? Are they pills? Do you sprinkle fairy dust on me twice a month? How, or is that different too?
It is. It's different. It's based on sometimes patient preference, sometimes compliance, what you can be consistent with. It's also sometimes based on your medical history. So estradiol is given in basically 2 forms. It's oral or it's transdermal. So transdermal would be skin-based. So that's troches, gels, patches, creams, anything absorbed through the skin. Oral is a pill that you swallow. And so there's different studies around which one is preferred based on your history. And those are daily usually daily applications, sometimes twice a week, depending on your form. And then with progesterone, it's oral. It can be given in cream form or troche form, but that is not uterine. That's not protective of the uterus. And it's been seen in studies to not protect the uterus as well. So oral progesterone that benefits sleep, provides uterine protection, and helps with mood. So oral progesterone. And then lastly, testosterone is given in the form of a cream or an injection. Pellets are available. We at Optimize You don't prefer that form because of just the highs and lows that women often get with those forms. So we'll do some microdosing on the injections. So a smaller dose more frequently.
Right.
And then we'll do cream that's daily. So there's a lot of different forms, and that, some of that is your choice. Some of that is based on your medical history.
Awesome. Thank you for coming on. I really appreciate it.
Thank you, Clint. Thank you.